Okay, so welcome to this next video in which we are discussing the role of the sarcoplasmic reticulum in pathological cardiac hypertrophy. Okay, so basically we've seen so far that pathological cardiac hypertrophy involves the cardiomyocytes growing in size but specifically in width, and that this initially leads to those cardiomyocytes being capable of generating a greater amount of force, but in the long term it actually leads to them being able to generate a lower amount of force than they were before they even underwent the hypertrophy. So we are now want to look at why do these hypertrophied cardiomyocytes have a lower capacity to generate force, and we're specifically looking at the role of the sarcoplasmic reticulum in that. So basically back to this dog experiment. So remember, we'd taken the dog, we inserted the pacemaker, which was giving it a tachy pacing, so it was giving it a tachy dysrhythmia, so its heart was beating far too fast. And this causes the cardiomyocytes within the dog to undergo concentric hypertrophy. So they're all undergoing this pathological cardiac hypertrophy because they can't cope with the tachydysrhythmia. Okay, and now what we want to see is what's happened in these cardiomyocytes. So basically the experiment we're going to perform is we're going to measure how much calcium is in the lumen of the sarcoplasmic reticulum. So, remember how the excitation-contraction coupling works. In order to get contraction of the cardiomyocyte, we need calcium to go up globally within the cytoplasm of the cardiomyocyte. And to achieve this, the calcium is released from the sarcoplasmic reticulum. Okay? So, if the calcium level were lower in the lumen of the sarcoplasmic reticulum, would you be able to release as much calcium from the SR? No. If you release less calcium, then the number of sarcomeres you'll be able to recruit within the cardiomyocyte to contract is going to be lower. So the force with which the cardiomyocyte will contract will be lower. Okay, so are sarcoplasmic reticular levels of calcium lower in these concentrically hypertrophied cardiomyocytes? Well, the answer is yes, but how did they measure that? So let's have a look at how you actually measure this. So, basically, what they used is a little drug that you'll probably never have heard of, known as caffeine. Okay, and caffeine, if you put it into cardiomyocytes, actually causes all of the calcium in the sarcoplasmic reticulum, or at least a good fraction of it, to be released. So let me explain how. So, let's discuss the drug caffeine. Okay, so we'll start with its structure, and its structure is very, very similar to the structure of the organic base, guanine. Okay, so in DNA you have organic bases. Two of them are known as the purinergic organic bases. So you have adenine and you have guanine, which are purinergic organic bases. And basically their structure is very similar to that of caffeine. So let me show you the structure of guanine, and then I'll show you the structure of caffeine and show you how similar it is. So, the structure of guanine then. So guanine, we begin with the pyrimidine ring. Okay, so these purine amine organic bases have a pyrimidine ring in, and you might think, well, that's quite odd, because the other organic bases, cytosine and thymine, they're the pyrimidines, but purine rings do have a pyrimidine ring. They just have it joined to something else known as an imidazole ring. So let me show you the structure. So a pyrimidine ring is a 6-membered ring, okay, where 4 of the members are carbons and 2 of the members are nitrogens. And the nitrogens have to be split apart by a single carbon in between them. Okay? And then you have alternating double and single bonds. However, in guanine, this double bond that would be here isn't actually there. So it's been broken apart by having a carbonyl group put here, and then you've got a hydrogen off this nitrogen. So basically you've broken one of the double bonds that you'd have there in a pure pyrimidine ring. So in a pure pyrimidine ring, if I draw its skeletal structure over here, the structure of a pure pyrimidine ring looks like this. So skeletal structures are nice because you don't have to draw the actual carbons, neither do you have to draw the hydrogens coming off the carbons. So this is a pure pyrimidine ring, at least the skeletal structure of it. So you can see that you've sort of got a pyrimidine ring sitting in this structure. Okay, right. So let's talk about the rest of guanine now. So you have an amino group coming off here. Okay, and then coming off here you have another ring known as an imidazole ring. So let me tell you what the structure of an imidazole ring is. So if I draw the skeletal structure again of an imidazole ring down here, then carbon, carbon, then you have nitrogens here which you can't get away with not showing even though it's a skeletal structure, and then double bond here and a single bond there. So you have 3 carbons here. It's a pentameric ring and 2 nitrogens, and it's known as an imidazole ring. And it's named imidazole because the name for a double bond between a carbon and a nitrogen atom, such as the double bond that you've got here, is an imide bond. Okay, so that's where the imidazole of this name comes from. So, continuing with our structure of guanine then, you have this double bond here between a carbon and the nitrogen there. Okay, so this is our imidazole ring, now linked to this pyrimidine ring. And when you have an imidazole ring linked to a pyrimidine ring, that is what is known as a purine ring. So when you add these together, what you get is a purine ring. So that's why guanine is known as a purine organic base rather than a pyrimidine organic base. In the pyrimidine organic bases, such as cytosine and thymine and uracil as well, you just have a pyrimidine ring. You don't have the imidazole ring added onto it. And then finally, just add on a hydrogen to there, and you've now got the complete structure of the organic base guanine. Okay, now let's have a look at the structure of caffeine. So basically, caffeine's structure is almost identical to this, except that you've got a few little alterations. So, start with the same basic ring structure. So you've got this 6-membered ring up here, where you have these 2 nitrogens and these 4 carbons. You've then got the same ring down here as well, with these nitrogens and the carbons, like so. You've still got the imide bond there. You've still got this double bond here. So everything's going nicely. This carbon's still got a hydrogen off it. The difference now is that this carbon here has a methyl group sticking off it. That's not the only difference, however, there's more difference, more to come. So that's the first difference we've observed. The second difference is up here. This is still a carbonyl group, but off this nitrogen, again, you stick a methyl group rather than a hydrogen. And then another difference is here. You do the same thing as you did up here. You cleave the double bond of the pyrimidine ring and put a carbonyl group off there, and then you don't put a hydrogen here. What do you think you put? A methyl group instead. So it's slightly different from guanine, but it's a very similar structure to these organic bases, guanine, and adenine is another very similar structure as well. So this is the structure of caffeine. Right, so what does caffeine do and why is it useful for our experiment? Well, basically it's useful if you want to measure the level of calcium within the sarcoplasmic reticulum, because what you can do is you can stimulate your cardiomyocyte with caffeine. Okay, and caffeine causes the release of all of the calcium from the sarcoplasmic reticulum into the cytoplasm. Now, how on earth does it cause this? Well, basically, caffeine binds to the type 2 ryanodine receptor. So let me show this here. So caffeine is going to come along and bind to our type 2 ryanodine receptor, which remember is this receptor sitting in the membrane of the sarcoplasmic reticulum, which allows calcium to come out of the sarcoplasmic reticulum and go into the cytoplasm of the cell. So caffeine is going to come and bind to our type 2 ryanodine receptor. So this is RYR2. Okay? And basically, it doesn't cause the type 2 ryanodine receptor to open, not directly, but it increases its sensitivity to calcium hugely. and it increases the sensitivity to calcium so much that the basal cytoplasmic calcium level is capable of stimulating this type 2 ranitidine receptor. So calcium level in the cytoplasm of a cardiomyocyte is not 0 at rest. I know when I drew these spikes, I drew it at nearly 0, but what did I tell you up here? Generally, at rest, it's 100 nanomolar, so it's practically 0, but it's not actually 0. So you do have calcium in the cytoplasm of the cell. It's tiny, and that's what we would call the basal calcium level. So the basal calcium level, which is around 100 nanomolar, is now going to be high enough, basically, to actually stimulate this type 2 ranitidine receptor to open. So let me review that argument. Caffeine binds to the type 2 ranitidine receptor, okay, and increases its sensitivity to calcium so much that the basal calcium level within the cytoplasm, the amount of calcium you have at rest, which is around 100 nanomolar. So this is not calcium capable of stimulating contraction. This is just the normal calcium that any cell would have in its cytoplasm before it undergoes a calcium signal. Okay? This is now capable of activating these type 2 ranitidine receptors. So you don't need the calcium sparklet from the L-type voltage-gated calcium channels anymore. The basal calcium that's just floating around the cytoplasm will be high enough to activate these type 2 ranitidine receptors. They will then just remain open and open and open, and they'll release all the calcium from the SR. So not only must calcium actually increase the sensitivity of this receptor to calcium, but it must also therefore stop the inactivation of the type 2 ranitidine receptor by the calcium. Okay, because remember, the type 2 ranitidine receptor was inactivated at high calcium levels, but if we're going to release all the calcium from the SR, then we can't have these type 2 ranitidine receptors undergoing inactivation, i.e. closure, because of the high calcium level. So caffeine must also do something about that. But basically what we know is that caffeine causes the release of nearly all of the calcium from the sarcoplasmic reticulum. So the calcium that was in the sarcoplasmic reticulum has now been moved into the cytoplasm. Now what's going to happen to it if we put it into the cytoplasm? Well, some of it's going to get pumped back into the SR by the Circa-2 pump, okay? And if it's pumped back into the SR, so here's our Circa-2, so some of the calcium will be pumped back into the SR. The problem is the type 2 ranitidine receptors will still be open, so it will just come back out again. So that was futile, basically. What's going to happen that's more efficacious, however, is that some of it will be pumped out of the actual cell cytoplasm by the proteins that were in the plasma membrane, i.e. the PMCA pump, the plasma membrane associated calcium ATPase, and also the sodium calcium exchanger. Now I told you that the rate of the PMCA pump is around 150 calcium ions per second, whereas the rate of the NCXs, the sodium calcium exchangers, is around 5,000 calcium ions per second. So the NCX is going to be the most important one. So basically what's going to happen is this calcium is going to be pumped out, it's going to be moved out of the cytoplasm of the cell into the extracellular fluid by the NCX pump. And we can measure the activity of the NCX pump. Why? Because it's electrogenic. It's moving 3 sodium ions in and 1 calcium out. Therefore, it moves 1 positive charge into the cell every time it works. So for every calcium ion that it pumps out, it's moving a charge, a single positive charge across the membrane. So we can measure this current, basically. Okay, and by measuring the size of the current across the membrane from these NCX channels, we can then determine how much calcium there must be in the cytoplasm of the cell that has to be extruded. So from that we can measure how much calcium came out of the SR when we stimulated with caffeine. So I'll repeat that argument. When we stimulate with caffeine, we can think that the SR has released all of its calcium into the cytoplasm of the cell. The calcium will then be extruded from the cell via the NCX pump. Okay, every calcium that is extruded in this mechanism will move a single positive charge into the cell. So by measuring the current that moves across the membrane, we can therefore determine how many calcium ions must have been extruded in this mechanism, and since nearly all of them are going to be extruded in this mechanism, that will give us a measure of how much calcium was in the SR lumen. Okay, so when we do this method, what we find is the amount of calcium stored in the sarcoplasmic reticulum of cardiomyocytes which have undergone concentric hypertrophy is lower. So the intracellular stores of calcium in hypertrophied cardiomyocytes is reduced, and this may well underlie the reduced contractility of those cardiomyocytes, because if the SR calcium is lower, then the amount of calcium that can be released every time the cardiomyocyte undergoes an action potential and therefore needs to contract is going to be lower. So if you release less calcium on each beat of the heart, then the number of sarcomeres you're actually capable of recruiting, i.e. the number of sarcomeres that will actually begin contracting in response to that calcium spike, is going to be lower, and therefore the amount of force that you produce upon that calcium signal is going to be lower. So the amount of force that the cardiomyocyte will produce when it contracts is lower, and that may well be one of the contributing factors to why these cardiomyocytes are producing less force. Okay, so we'll continue this discussion in the next video, where we'll see that actually it's the circa 2 pump's fault, basically, that the calcium is too low in the sarcoplasmic reticulum.